training and work in neuropsychological assessment. Through that time and her time here, she has carved out a niche for assessing for and treating ADHD, autism, and learning disorders specifically. Brooke is amazing in that not only does she bring her expertise to the field and to her assessments, she is thorough, she is engaging, she is warm, and I'm sure you'll experience that from her. On top of that, she also has her own lived experience with ADHD, so she can really meet folks where they are, understand the perspective from a person with lived experience, and we really appreciate the expertise and knowledge and support that she brings to us. She's been with us since last fall, and right now she is doing a mix of these psychological assessments as well as therapy for adolescents and adults, and she does some executive functioning skills and ADHD coaching for us as well. So with that being said, I want to turn it over to Brooke, and feel free to put any questions you have in the chat.
All right. Well, hello. I'm very happy to have everybody here today to listen to me talk about my special interest for the next hour, because there is nowhere I would rather be. So just a really quick overview of what we're going to cover today. I am going to talk about what is ADHD and also what ADHD is not. We're going to talk about how ADHD is diagnosed. We'll talk specifically about what an evaluation looks like here at Hello Mental Health, and then what happens after the assessment. So we get somebody in, we do an assessment, what comes next? So I know today we have a bit of a mixed crowd. So there's a lot of other clinicians, we have some clients, we also have just people who are generally interested in ADHD. So I'm going to go back to the basics to get us started, and then we'll get a little bit more specific from there. So ADHD at its core is a neurodevelopmental disorder. Big fancy way of saying this is a disorder that we expect to see across the lifespan. So we don't necessarily expect somebody to have the exact same symptoms across their lifespan. And we don't expect every child with ADHD to look the same and every adult with ADHD to look the same. All we're looking at is the fact that there are some signs or symptoms of the disorder across a person's lifespan. So ADHD in the DSM, so the DSM, the Diagnostic and Statistical Manual for Psychiatric Conditions, this is the kind of basis of most psychiatric diagnoses. And ADHD in the DSM has been relatively unchanged since I started in the field. There was a lot of talk and a lot of rumbles and rumors that there were going to be some significant changes with the DSM-5, but that did not come to fruition. The symptoms are basically identical from the DSM-4 through current. They have just added some examples of ways that it might manifest specifically in adults. So there are 18 total possible symptoms of ADHD, and those are divided into two broad categories. So we have 9 symptoms that fall under the kind of umbrella of inattentive symptoms, and 9 symptoms that fall under the umbrella of hyperactive or impulsive symptoms. So inattentive symptoms of ADHD are things such as poor sustained attention, or a lack of persistence in tasks. Particularly, this comes up when the tasks are boring, repetitive, tedious, not something that the person finds intrinsically appealing or interesting. We also see this come up in terms of problems with working memory. So working memory is a subset of short-term memory. And with working memory, we keep a certain amount of information in our brain and actively manipulate it, work with it, use it until we either forget it or transfer it into our long-term memory. So with this symptom in particular, you might see this come up where somebody walks into a room and it's like, why am I here? What am I doing here? Or somebody is telling a long-winded story and they get to the end and it's like, I don't remember what the point was. All of those tend to be attributed to issues with working memory. We can also see things such as diminished problem-solving ability or diminished flexibility. So oftentimes, particularly over time, people with ADHD may develop systems that help them cope with any of the negative impact of the disorder. And that can lead to some inflexibility if things change in a way that is not helpful to the way that they are used to doing things or the way that they're used to managing their symptoms. Then that second category is the hyperactive impulsive symptoms. And this is what we often think of kind of in media with like, the little boy in the classroom who's climbing the bookcase in the back or darting out into traffic or running away from his parents at Disney World. It's kind of the stereotypical presentation. But it can also include things like impaired response inhibition, or impaired impulse control. And this can be relatively minor, things like interrupting people while they're speaking or finishing somebody's sentence, not waiting your turn in a game or waiting your turn to speak. But it can also cause bigger problems. So it can be a lack of impulse control when it comes to spending, and people can spend more money than they're comfortably able to do. It can be issues with impulse control while driving. So you often see, an increased rate of car accidents or speeding tickets, especially among adults with ADHD. It can also be difficulty with delayed gratification. So essentially, if you are waiting to do the thing you have to do before you get a reward for it, that can be really kind of itchy and uncomfortable in an ADHD brain. We can also see this in terms of difficulty regulating emotion, regulating motivation, regulating arousal. So people can become kind of emotionally labile. So really quick shifts in emotion or emotion that's really reactive to things happening in the environment. You can see differences in terms of arousal. So sometimes people with ADHD do pretty well in a lot of settings, but if you put them in a setting where I keep saying where we're overstimulated, you end up not being able to cope with things quite as well, and the symptoms tend to become more pronounced. It can also be, like I said, issues with motivation, and this isn't this isn't laziness. This isn't just like, oh, I don't want to do this. I'm not going to do this. This is everything in your body saying, I need to do this thing, and I want to do this thing, and I know I can do this thing. And yet there is something in my brain that will not let me do the thing. So this is where we see some of the issues come up with hyperactivity and impulsivity. So when we're diagnosing ADHD, somebody needs to what we call meet criteria. And all that means is that out of the 18 possible symptoms of ADHD, children need to have at least 6 symptoms and adults need to have at least 5 symptoms. But they need to be spread out in a certain way. And that's because when we diagnose ADHD, we assign one of 3 subtypes. So there is a predominantly inattentive subtype where the person as an adult will meet at least 5 criteria of the inattentive symptoms, and they will meet fewer than 5 criteria of the hyperactive impulsive symptoms. And so this tends to be a presentation where somebody is really prone to daydreaming, really prone to kind of getting lost in their own thoughts or distracted by thoughts. This could be somebody where, you can kind of trace what they did during the day based on the trail of things that they left behind. So, if you are on social media, you'll see a lot of examples where people talk about, they were in the kitchen and they went to go put a dish rag into the laundry. And so they walk into the laundry room, but then they realize that they had never moved their laundry from the washer into the dryer. So they have to do that. But then there's stuff in the dryer, so they have to clear that out, and they go up to the bedroom where they realize that they didn't make their bed, and so on and so on. And so eventually you get back to the point where the dishes never got done. All of these other tasks were partially completed, and you could kind of trace the person's pattern over the course of the day. The second subtype of ADHD is the predominantly hyperactive impulsive subtype. And this is for people who, for adults who meet at least 5 of the hyperactive impulsive criteria, but fewer than 5 of the inattentive. So this tends to be people who might have more difficulties with impulsive spending, or really quickly starting and stopping relationships, leaving jobs when they get frustrated, and instead of tolerating that frustration, it may manifest as a big blow up and they walk off. And then the third subtype is the combined presentation, where the person meets criteria for both inattentive and hyperactive impulsive. So they have at least 5 symptoms in adults from each. And the way that we type ADHD is based on their presentation in the past 6 months. So one thing that's really interesting, I said that this is a neurodevelopmental disorder. We expect to see some signs or symptoms across the lifespan, but people don't necessarily meet criteria in the same way across the lifespan. So for that reason, we type it based on what they've been experiencing in the past 6 months. So it is not uncommon for people to essentially outgrow the combined presentation as they learn more subtle ways to mask some of the hyperactive impulsive symptoms in a way that they are no longer causing interference. The other piece of diagnosing ADHD is that we want to see functional impairment across domains. So all this means is we want to see evidence that this person is struggling, that this person is not living up to what we would expect based on their general ability level, based on their education, based on their training, across domains. And this can be problems at work or school. This can be problems in relationships. It can be problems managing the home. We also, as I said, we want to see evidence across the lifespan. This isn't to say that people will necessarily meet full criteria for a diagnosis across the lifespan, but these symptoms should not be just kind of sporadic, happen for a month and then go away sort of symptoms. We want to see some evidence that the person is dealing with symptoms across the lifespan from childhood. In the DSM, it says before the age of 12. There's a controversy on whether adult onset ADHD is a valid diagnosis that goes well beyond the scope of what we're talking about today. But in cases where somebody has sustained a serious head injury, or has been exposed to toxins, or has developed certain medical conditions, we can see ADHD that develops later in life with no symptoms in childhood. And then we want to make sure that the symptoms are not better attributed to a different psychological or medical diagnosis. So if you want to play a really fun, really nerdy game, pick up the DSM, open it to a random page, and I would be willing to bet there is, I don't know, 30 to 50% chance that difficulty concentrating or restlessness or things like that fall into the diagnostic criteria. It's in the criteria for depressive disorders, for mania, for anxiety, for post-traumatic stress disorder, substance use disorders. It's kind of across the board. So we want to make sure that if somebody is experiencing difficulties sustaining attention, difficulties with restlessness, difficulties with motivation, with sleep, with all of these sorts of things, we want to make sure that that's best attributed to ADHD and not just the result of another condition. And part of the reason for that is we like to have really clean diagnoses, despite there being so much symptom overlap. But there are also different ways of treating the symptoms based on their etiology. So if it is not based in kind of the brain differences that we see with neurodiversity, with ADHD, with autism, if it's not based on that, but rather, a lack of serotonin because of depression, the treatment is going to look very different. So despite us being probably at least a decade or more away from objective diagnostic criteria, so brain imaging, genetics, that piece of it, there's research happening, but we're a long way from where that's going to be kind of our standard for diagnosis. At this point, we are in pure psychological, it depends realm. Okay. So how do we diagnose ADHD? It varies across providers. There are a wide array of different providers who are qualified to diagnose ADHD. This ranges from physicians, nurse practitioners, psychologists, counselors, social workers, et cetera. There's anybody who has a bit of a medical or psychological background and additional training in ADHD and the way that it manifests is theoretically capable and of diagnosing, and that diagnosis should be accepted pretty widely. One area where I think medicine, and so where psychiatrists, where physicians, where nurse practitioners are a little bit handcuffed by our insurance system in particular, is to do a really thorough interview for ADHD. It estimates should take about 2 to 3 hours. I don't know the last time that I met with my physician for more than 15 minutes. And so this is where people who are psychologists or counselors can really help fill in some of the gap and work within our current medical system to be really helpful to medication providers, because we're allowed to and given the freedom to do these more comprehensive diagnostic assessments. So in a good assessment, we want to get a really clear picture of how the symptoms appear for this person. And there is no such thing as just a yes or no sort of answer when it comes to assessment. I come from a really strong research background. Michigan State is a clinical science program. So I worked in a research lab doing diagnostic interviews for 4 years. And while no can sometimes be a complete sentence, yes is never a complete answer. Yes is simply an invitation to probe further. So when we are assessing symptoms, we like to get as many details and as many examples as possible. Because like I said, we're not dealing with objective brain scans, blood tests, genetic studies. We are really dealing with the minutia of people's subjective experiences. So historically, the gold standard for psychological assessment, Michelle, did you have?
No, sorry, I was anticipating a question that I had for you, but I turned my camera on prematurely, so I apologize for
Not a
that.
problem.
Yeah.
So the historical standard for, at least for psychological assessment of ADHD, has been a comprehensive neuropsychological battery. And so this would include things like, in addition to the clinical interview, a test of general cognitive functioning, or kind of in lay terms, an IQ test, a test of academic functioning. So seeing where people's skills fall in reading, writing, and mathematics. There would be tests of executive function. So executive function is anything that falls under the control of the frontal lobe. So things like planning, prioritizing, task initiation, sustained attention, the list goes on and on. There would also be tests for memory, in particular working memory. And then often there would be a continuous performance test, which is a computer-based test where a person is asked to do a very, very boring task, typically either watching dots or listening to a tone or identifying between like 2 categories for a long period of time. usually 25 to 45 minutes. And the way that the computer provides the stimuli varies. So in theory, you are supposed to be able to pick up on a person's ability to sustain attention, their impulsivity, and the types of errors that they tend to make. And so for the longest time, this was kind of the gold standard for ADHD assessment. And it's still the gold standard in a lot of areas. So if somebody is applying for Social Security disability, if somebody is applying for accommodations at school or at work, if somebody is looking for like accommodations on big tests, SATs, GRE, LSAT, whatever it might be, those boards still require this kind of testing. But in the past decade, this has actually become really controversial. So back in 2019, Russell Barkley, who is kind of a world-renowned expert in ADHD, published an opinion piece in his journal. And I'm going to read off the title because it's just brilliant. Neuropsychological testing is not useful in the diagnosis of ADHD. Stop it or prove it. And the entire idea in this piece that he wrote was that we do this comprehensive neuropsychological battery and say that this is necessary to diagnose ADHD. But research has shown time and time again that people with ADHD show greater variability than neurotypical people in task performance. So we wouldn't expect to see an ADHD pattern in testing. We would just expect there to be variability. But neurotypical people also show variability in testing. So we're not really teasing anything apart there. Also, he liked to talk about how there is just a difference in terms of doing this testing in a very controlled environment. So when we do neuropsychological testing, in school, we are instructed down to the tiniest little details. What are we going to put up on the wall so it's not distracting? What are we going to, what kind of noise machine, like what sort of sound machine do we have? What sort of things do we have in the room? If we test kids, do we keep the toys in a different room? Like, this is a very sterile, atypical environment that essentially is setting somebody up for success because there are no natural distractions. So again, it's
So
a
Brooke,
really, yeah.
sorry to interrupt. I just
No,
wanted to make sure that we're on time. How at Hello Mental Health have you tried to overcome these barriers? What does your assessment look like as opposed to this sort of neuropsych gold standard that just isn't practical?
sure. So we do offer that if that is what a person needs. So like I said, if somebody is applying for school accommodations, if somebody is applying for test accommodations, workplace accommodations, those institutions typically require this type of assessment, and we are able to provide that. But when we designed our assessment practice here, we set it up in a way that aligns with the research. So I am unbelievably lucky in that I came into this and was basically just given carte blanche to set up our testing services how I saw fit. So being the clinical science nerd that I am, I went to the literature to look for best practices. And turns out that several of the articles on best practices were written by my child assessment instructor, Joel Nigg, which is just kind of funny. It's a very small world, mental health. But I largely used an article by Maggie Sibley, who is, again, an expert in ADHD. And she published an article about empirically informed guidelines for adult ADHD assessment. And that is what we do for most of our assessments here. So the first thing that we do before I ever meet with a person is we send out these initial screening measures. And screening measures have really good sensitivity. They're really good at picking up on if a symptom is there, but they also produce a lot of false positives. So you have a lot of people who will endorse symptoms that are consistent with ADHD, but they're experiencing it for different reasons. But it's a really good way for us to get started and for me to know what direction it might take when they come in for their first appointment. So when they come in for their first appointment, we do a clinical interview. So I get a lot of background information. I want to know about who they grew up with, what happened in their home, what school was like for them, kind of across the board, what their relationship was like with their peers, what their relationship were like with friends, if they're older, what their romantic relationships have been like. I want to know if there have been any medical conditions that can contribute to this. You know, we're finding, as research is starting to focus more on um, ADHD in women, we're finding that hormonal fluctuations can greatly impact the experience of ADHD symptoms. So I want to know if they're perimenopausal, if they've had their hormone levels tested. I want to know if there've been head injuries or if they've had COVID and now have long COVID, because we're also seeing a lot of ADHD symptoms attributed to long COVID. And then we dig into the symptoms themselves. And the gold standard for that is to use a structured diagnostic interview. So typically to assess ADHD symptoms, we use something called the DIVA, not just because it has a great name, but it is a really good structured interview that assesses all 18 possible symptoms of ADHD in the past 6 months, as well as during childhood. So like I said, this is neurodevelopmental. We want to see, even if it doesn't look the same, we want to see evidence across the lifespan. And it gives a ton of really good examples of how these symptoms might appear at different times in a person's life. So I find it's a really useful tool where somebody might initially say no to the symptom. You know, do you have trouble completing chores at home? And they'll be like, no, not at all. It's like, okay, do you ever forget to return something that you purchased and meant to return? And you kind of see the light bulb. And this is where I feel like maybe that lived experience can be extremely helpful in knowing what to ask because I know what things I struggle with. I know what things, you know, I've done thousands of these assessments. I know what things tend to come up. And so we really look at that. We really assess for that. Um, and so we also, the DIVA does a really nice job of assessing for impairment. So there are 2 full pages, both for adulthood and childhood, where we are looking at the ways in which these symptoms are impairing the person currently or ways that impaired them during childhood. And it also allows for uh, a little bit of wiggle room. So one thing that I have found in doing these assessments is that people with ADHD can be some of the most creative, brilliant sorts of people who come up with amazing ways to mask symptoms or to not let symptoms interfere. So in the DIVA, it explicitly says things like they had limited impairment due to high IQ, limited impairment due to imposed external structure. And so it really allows us to look at the person's individual experience and determine if there is impairment. The other thing that we do is we give people normed rating scales. So these can be things like the BARS, which is Russell Barkley's ADHD assessment. It can be the CARS, which is like the Connors adult assessment, the brief, anything like that that really addresses symptoms and allows us to look at them compared to other people diagnosed with ADHD as well as neurotypical people. And the other nice thing with those rating scales is they almost always come with a self-report as well as an observer report or an informant report. So another piece of the assessment that is really important is getting what we call collateral information. That can be asking for school records if they're still in school. It can be talking to people who know them well. We typically try to interview or send out rating forms to a parent, a best friend or a partner, somebody who has seen this person in different domains and might have a good sense of how these symptoms impact them and how they come up. And one thing that Dr. Sibley really emphasizes with these symptom rating scales is using what she calls the or rule as opposed to an and rule. And all that means is that if one person that we are giving this to endorses the symptom, we count it. We're not always great at seeing how things manifest in ourselves. Also, people with ADHD tend to mask their symptoms. So it may be that someone in their workplace might have no idea that this is going on because they've gotten really, really good at masking symptoms in the workplace, but that uses their entire executive functioning battery for the day. They get home and things fall apart. So using the OR rule lets us really delve deeper into things that people see about themselves, but also things that other people see about them. The other reason this is important is that just symptom level disagreement is really common. We don't want to rule something out just based on the fact that one person didn't see it. And then we use a structured diagnostic interview for any sort of rule outs or comorbid diagnoses. And this is where those initial symptom rating scales or larger scales like the PAI, the Personality Assessment Inventory, really help narrow down what we want to further assess. But I'll use the SCID, the Structured Clinical Interview for DSM-5, or I'll use the Diamond. I do not know what that stands for, but it's free and available online if you Google the Diamond interview. And we use that for any sort of comorbidity or rule outs, because like I said, the symptom overlap is intense. You could make a really fun drinking game out of counting how many times like difficulty concentrating pops up in the DSM. So that's the assessment. They come in, they do these things. If they do not need accommodations, if they aren't applying for disability, if they're not doing something like that, we generally stop there. That gives us enough information to confidently say if a person does or does not meet criteria for ADHD. If a person is really curious about ways that these symptoms are presenting for them, if they want to do more testing, we certainly will do that. The whole point behind that article that Russell Barkley put out was we are creating barriers to diagnosis and barriers that are based on a misconception of the research. And so we want to make sure that we are providing assessments that fully answer a person's questions, fully help them understand what's going on, but are not so cost prohibitive, time prohibitive that it can't happen. Because one of the things that people may not realize about neuropsych testing, every test kit is thousands of dollars. You pay for every administration and every scoring of every test that you give. So there is no way to do that level of testing and have it be accessible to everybody. Insurance is really limited in terms of what they will cover and what they will pay for testing. And so we really tried to set up an assessment system that created a customized, we call it kind of right size, right fit assessment for each client who comes in here. So that's the assessment. When they're done with it, they usually walk out of the room with a pretty good idea, kind of what we would call a provisional diagnosis. So pretty good idea of what's going on. And then we put together the data, we put together all of the information that we gathered, and very clearly lay out things that other providers might want to see. We are really big here at collaborating with other providers. Almost all of the people that I've assessed have been referred to us by either medication providers in the community or other therapists in the community. And there's no bigger honor than people trusting you enough to send you their clients, because we all know how much we care about our clients. We want the best for them. And so when people send us a client, we're so grateful, and we want this to be the best experience for the client and for the people who are doing the referral. So we will put together kind of written documentation of what symptoms the person meets, how they meet those symptoms, what some of the more objective, like it's still subjective, but some of the more on paper normed data say for this person. And then oftentimes I will set up a phone call with their provider just to go over some of the ins and outs that don't necessarily make it into a report. So talking about ways that this could manifest in therapy, different therapeutic approaches that can be helpful for the person, And then information that I might have gleaned from either the interview or from the PAI, which addresses kind of functioning across domains and ways that that can be useful to their provider. So after they're done with the assessment, what happens next? If they don't have ADHD, we want to figure out why they're experiencing the symptoms that they're experiencing. So we want to try and figure out if there's another diagnosis that might be a better fit and might better account for what they're experiencing. We want to connect them with therapy, not only because they're experiencing something that was severe enough that they came in for an assessment, but also it can be a really difficult thing to either meet or not meet criteria for a disorder. So if somebody's coming in expecting an ADHD diagnosis and that's not actually the best fit diagnosis, that's something that we want people to really explore. We want people to really, uh, you know, get in touch with maybe some of the disappointment or the confusion that can come up from that. We also will collaborate with medication management if they are experiencing symptoms because of severe depression or anxiety or those sorts of things. So we have a lot of folks out in the community that we can collaborate with, that we refer people to make sure that they're just set up with the level of treatment that makes them feel the most supported. If they do have ADHD, we will typically help them with a referral for medication management if they're interested in trying medications for ADHD. We also offer executive skills coaching, which is something that is not therapeutic. It's very separate. It's really directive. We assess specifically what strengths and weaknesses they have in their executive skills. And then we look at ways that they can change the way that they're approaching things, maybe ways that they can change the environment to better support them, or ways that they can bring other people on board to help support them, to not allow any of these symptoms to limit their ability to perform in the neurotypical world that we live in. We also do therapy afterwards. If a person does not have a therapist and they would like to do therapy, we will bring them in, and this is where we get to move away from the medical model of ADHD. So diagnosis is very much within this medical model. We have criteria we have to stick to. We're looking at things as symptoms and disorders and all of this, when really the research and the field is moving towards a much more neuroaffirming perspective. There are differences in the way that people interact with the world, but they're differences. They're not disorders. And so this is the area where we're really able to help people learn to cope with frustration, learn to kind of reconcile, especially if they're being diagnosed as an adult for the first time. They may have really internalized messages of they're not good enough, they're lazy, they're not smart enough, they can't do things. So really starting to look at some of those messages, where they came from, and evaluating how things might have been different had this been known earlier. And then there are other problems. Yeah.
I was just going to ask, first of all, I want to remind folks that as we approach the question and answer section, you're welcome to put questions into the chat. Also, Brooke, can you explain, does somebody have to choose ADHD or executive coaching versus therapy, or can they do both at the same time?
Definitely do both at the same time. So I have some clients where we're doing therapy and I like to integrate some of the coaching into it. I also have a number of clients for coaching who have therapists. And a lot of times what we'll do is alternate weeks. So they'll see their therapist one week for therapy and then me for coaching the next week. Coaching can also be, because it's really directive and we're teaching people new skills, it can be short. I do 30-minute coaching sessions with people where we'll meet every week, but only for 30 minutes, because it can get overwhelming to learn all of these new ways of trying to approach things. So 30 minutes is enough time for me to introduce something, come up with a way that we're going to have them implement it, and then they get to try it out and come back the next week and evaluate how well things worked for them. So they're not mutually exclusive. And it's something that I offer not only to clients that already have a therapist, but I love training other clinicians on how to incorporate executive skills coaching and kind of an understanding of executive skills into their work with clients. So I collaborate with some of my assessment clients' therapists so that they're able to learn kind of either what I'm doing with their client or learn new ways to help clients.
Sounds like we know what your
Yeah.
next webinar is going to be.
Yeah. And then because ADHD has more comorbidities than just about any other disorder, that is something we try to address in therapy as well, is if there are other comorbidities, it tends to go hand in hand with depression, substance use, anxiety, a lot of other comorbid disorders. So we want to make sure that we don't just attribute everything to ADHD, and we're really addressing other disorders that come along with it. So I can talk all day. If you
Yeah.
couldn't tell, I'm chatty. But I will stop here. I want to respect everybody's time, and I want to have people feel like they have time to ask questions. So I'll stop and open up the floor to everybody else.